So when do you need to worry about the adult female with acne? Well, somebody who's older, of course, somebody who has an abrupt onset. So let's say a 40-year-old who suddenly has considerable inflammatory acne. Of course, we're looking for signs of virilization, hirsutism, alopecia, acanthosis nigricans, clitoromegaly. In those patients, we're going to be doing a hormonal evaluation. This should be done during the first week of the menstrual cycle. Basically, you need to miss ovulation. We're looking at testosterone, both free and total. Total is, of course, the testosterone that's bound to the sex hormone binding globulin, right? And then the free is the testosterone that's circulating by itself. DHEAS, looking for adrenal androgens. And we want to look at LH and FSH. Not just the numbers themselves, but the ratio of LH to FSH. If it's more than 2, it may indicate polycystic ovarian syndrome. Finally, the biggie, isotretinoin, indicated for nodular cystic acne unresponsive to conventional therapy. So again, technically, the patient has to have been on and failed something else before the FDA approved use of isotretinoin. It's the only acne medication that stands the chance of curing acne. About 80% of patients who finish a course will never see acne again. Of course, it has numerous potential side effects, which we're all well aware of, but few of them actually occur. Dry mucous membranes, everybody, 100%. But the next most common is triglyceride elevations in about 25% of patients. Then muscle aches and pains in 18%, and liver function abnormalities in 11%. Those are the only side effects that actually occur in more than 1% of the patient population. So I see it as my job to help the patient to put into perspective the real side effects, what actually might happen from the internet hype. Because if you don't do enough to make sure that the patient is given a rational list of side effects to look for, the patients are going to become afraid of this drug and they're not going to take it. What patients and parents are specifically worried about in my practice is depression and inflammatory bowel disease. So let's take a look at some important mental health statistics when talking about this age group. Just being 18 to 25 years old is an independent risk factor for mental health issues. Mental illness is the highest, major depression is the highest, and suicide is the second cause of death in the group that is most likely to be on isotretinoin. Having acne is also an independent risk factor for depression, anxiety, and suicidal ideation. Depression is 2 to 3 times more common in acne patients than the general population, and suicide ideation is 2-fold higher in girls and 3 times higher in boys in patients who have severe acne. So the background noise is enormous in this patient population. We have 2 meta-analyses that look specifically at the risk of depression on isotretinoin. This one is a meta-analysis of 31 studies that showed a relative risk of depression that was significantly declined and a mean depression score which was decreased while on isotretinoin. And this study that looked at 20 studies found that 3 showed no association of depression with isotretinoin. 17 studies showed an improvement in psychological well-being. So the conclusion of these authors was that the use of isotretinoin is associated with significantly improved depression symptoms. Now, that doesn't mean we shouldn't be careful and we shouldn't be watching our patients. We should have a high index of suspicion, but there really is very little evidence that psychiatric problems are caused by isotretinoin. Same thing for inflammatory bowel disease. Here we're looking at Crohn's on the left and ulcerative colitis on the right. You see the peak incidence of both of these conditions, again, right smack dab in the middle of the age group that's used to treat isotretinoin for acne. As you can see, it tends to present before the age of 20. There's a high family history in both, but particularly in Crohn's disease. A 26-fold risk if a sibling is affected, 50% if the patient is a monozygotic twin. And there's also an association with the prior use of the tetracycline class of antibiotics with inflammatory bowel disease. Whereas ulcerative colitis, not so much. 8-fold increase if sibling is affected, and about a 19% increase if a twin is affected. So what does all this mean? To me, this means that if I have a patient who has siblings with Crohn's disease, especially if it's a twin sibling, I'm going to think twice about using isotretinoin because the incidence of Crohn's is so high. Now, I'm not saying that isotretinoin is going to cause the Crohn's. I'm saying this patient has a high risk of developing Crohn's, and I know the drug, and I am going to be blamed for it. So perhaps we need to be looking for a different drug. But ulcerative colitis, I don't feel as strongly about. So what data do we have? Well, this all started in the early 2000s with a couple of case reports of ulcerative colitis and Crohn's with isotretinoin. And this case-controlled study, though, showed minimum dose-dependent risk for ulcerative colitis, but not for Crohn's. 4 large case-controlled and cohort studies showed no link with inflammatory bowel disease. A large Mayo Clinic study showed a reduced incidence of inflammatory bowel disease, and a meta-analysis of 9.7 million pooled patients showed no link with inflammatory bowel disease. So to my satisfaction, this too has been put to rest. We have a couple of other isotretinoin issues that I'd like to discuss briefly. Reducing the risk of relapse, laboratory monitoring, what are we going to test, how often are we going to do it, and finally, pseudoacne fulminans. So the risk factors for relapse include things that we can do something about and things we can't do something about. Men, back and trunk, milder or more severe disease, linear disease, which is really sort of hidradenitis suppurativa of the face, macrocomedo predominant acne, patients who are younger when you treat them with isotretinoin, women with ovarian dysfunction, and insufficient dosing. And of course, insufficient dosing is something which is basically our fault. We haven't given them enough medication and therefore they relapse. Here we see a graph showing that relapse is more common in younger patients. This is the percent of patients needing more than 2 treatments. So you can see that young group, the 10 to 11 in the yellow, a very high risk of needing 2 treatments or more, and going down until you reach its nadir at about 18 to 29-year-olds. So in my practice, I try my best not to treat patients under the age of 16 with isotretinoin. I look for alternatives because I know if I wait, they're more likely to need to have retreatment. But the bottom line is, if I need to retreat, it's not the end of the world. And there are plenty of 14-year-olds who very badly need isotretinoin. So I wouldn't worry about it, but just know that they're more likely to relapse. It's certainly something that needs to be discussed with the patient and or their parents. So what about not giving them enough so that they end up with a relapse? Well, that requires knowing what an insufficient dose is, doesn't it? Insufficient cumulative dose can be due to noncompliance on the part of the patient. It can be due to poor absorption of isotretinoin, or it can be used to us due to us using too small a dose or too short a duration. So let's talk about poor absorption. Isotretinoin is a lipophilic drug that requires consumption with a fatty meal in order to absorb it really well. Food-independent alternatives do exist, the Litos formulation and the new micronized formulation of isotretinoin, that don't depend on stomach contents, but generic isotretinoin does. And lastly, what's the sweet spot? What's the right dose to be giving our patients? Well, it might surprise you to know that we don't know the answer to that question. We know that there's a cumulative dose that's too low, but we don't know what that is. And the upper end is also unclear. Relapses can occur even at high cumulative doses, above 220 milligrams per kilogram in one study. For many years, we've been saying that the cumulative dose of 120 to 150 milligrams per kilogram is the sweet spot. But is there data that actually shows that that's true? Jerry Tan suggested that the dogma of 120 to 150 milligrams per kilogram as the ideal dose does not have robust support, and that additional studies need to be done to define that cumulative dose that maintains remission. The global expert group recommendations say, well, get to at least 120, treat for at least 6 months, and extend treatment until the patient has been clear for at least 1 to 2 months. Low-dose regimens, although they're associated with higher patient satisfaction because there's fewer side effects, might end up causing relapse. And since we don't know how low is too low, personally, I aim for that 120. Because relapse, not efficacy, is the pertinent endpoint of isotretinoin use.